having us this evening. And thank you all for being here to hopefully gain something valuable and educational about your pelvic floor and its overall function and kind of what you can do or what you don't have to live with necessarily. A lot of people live with a lot of different struggles with their pelvic floor and they don't know that things can be helped. So hoping to shed some light on some of those things today. I'm a physical therapist. Our clinic is just down the road, down Redwood Road. Missy's a physical therapy assistant. Therapist assistant. How did I mess that up? And she's really our pelvic floor guru here in our clinic. I will typically do the first visit with people, kind of just to make sure that you're appropriate for pelvic floor physical therapy, and then she takes the reins from there and works her magic. So before we get started, we didn't see that there were any questions submitted, but wanted to kind of open it up if there were any specific questions that y'all had or things that you were hoping to learn or get out of tonight. We wanted to make sure we cover that first. Do you have anything pressing?
I know sometimes too, like pelvic floor can be such a taboo subject that's like uncomfortable to talk about. So if at any point it's like I do have a question but I don't want to ask it in front of everyone, you can ask us individually as well. Just so you know.
Yes. And there's never such thing as too much information when it comes to pelvic floor function.
Yeah, for sure. Are there any questions just off the top here? Or anything specific you guys want to learn, want to focus on? Cool.
How many of you have issues with your pelvic floor? You feel like you have issues with your pelvic floor? Got some hands? Okay. Okay.
How many of you do you feel like you've been having issues for more than 6 months? How many of you have had a delivery of some sort, whether it was like a C-section, vaginal? Cool. Okay. I think that was everyone. Okay. Well, just to kind of start off, we wanted to talk about what the pelvic floor is, right? So the pelvic floor is literally the base of your trunk. There's technically 3 layers of the pelvic floor, and depending on which layer you might have a muscle imbalance on can kind of depend on like what sort of symptoms you're having. With pelvic floor situations happening, there's like really 4 things that can be happening if you have problems with the pelvic floor. The first one is like leaking. So whether you're like sneezing, laughing, coughing, exercising, any sort of thing like that. There can be a heaviness, which can just make it feel like something is coming out or something just doesn't feel normal, and that's most likely due to a prolapse, which is something that we can treat with pelvic floor. There can be pain, whether that's with intercourse or just exercising in general, and then there's also can be like the ab separation or the diastasis recti. So we'll kind of like go over each of those topics. If one of them is more interesting to you guys than the other, then we can talk more about that. But essentially, so the pelvic floor is basically a part of your core canister. So when you think about the pelvic floor, it's sitting at the base of your pelvis, right through here. A lot of times if you are having pain in the pelvic floor, it can refer pain to the back, it can refer pain to the hip, it can refer pain really pretty much anywhere from T8 down. So it can be referring to a lot of places. But like I said, there's 3 layers. That 3rd layer, that's the deepest layer down in here, is actually a hip external rotator muscle. And so a lot of times hip pain will be very common with pelvic floor dysfunction. Do you want to talk about leaking?
I have a question.
Yes.
Yeah.
When you say hip pain, where would you experience the hip pain?
Really anywhere. It could be back, it could be side, it could be front.
Like inner thigh, all the way around.
Yep.
Thank you.
Yes. First, are there any questions about like the pelvic floor? Anatomy wise.
And this is the back side, that's the front side.
Yes.
Sometimes it's hard to see without the rest of the body.
Just like this.
What are all the parts that hold out?
This is the uterus. This is the bladder, and this will be the rectum. So one of the main components of the pelvic floor is to hold all of the organs, right? And when you think about it, like, so if you're standing here, pelvic floor is at the bottom, diaphragm's at the top, and then your spinal muscles and your abdominal muscles are what make up the core canister. So that's what helps with like all of the pressure going on into your body, and trying to keep that equal is the hope. But a lot of times that pelvic floor, since it's constantly taking all the weight, that's where we can get a lot of pelvic floor issues as well, especially with like exercising and things like that.
So is the pelvic floor like a muscle?
Mm-hmm.
So it's a muscle that kind of goes over that area.
Yep, so that's exactly what it is it's just muscle.
So all of the red on this pelvic model is muscle tissue. So it's a series of many muscles that function together. And so there's some inside the pelvis, there's some outside the pelvis. So all of the red is muscle there.
And it's all like the pelvic floor muscles, basically.
Yes.
Any other questions anatomy-wise? Okay, we'll start probably with leaking. I feel like that's very common.
So something that's really cool about the pelvic floor is it's got unique innervation. So there's innervation of the pelvic floor where you can voluntarily contract the pelvic floor and get those muscles to engage on your own. And then there's also automatic contractions that should be happening regularly that sometimes doesn't happen, and that's when you can start to get symptoms of heaviness, leaking especially. In an optimal functioning system, you're not having to consciously squeeze your pelvic floor when you sneeze or cough or when you're jumping, those kind of things. It should be automatically happening when there's an increased pressure intra-abdominally. So a lot of times the pelvic floor leaking is more of a symptom of something that's gone wrong in the system and it's not functioning well. So when I'm working with pelvic floor cases, I do what I call an external orthopedic approach to try to find where in the system things aren't working well for that pressure management, specifically for what we call stress incontinence, which is when we do leak, anytime there is increased intra-abdominal pressure. So increased intra-abdominal pressure just means there's pressure like below your ribs, and then any pressure in the stomach, ab area, pelvis area, pushes downward and the pelvic floor has to manage that pressure. When there's a mismanagement of pressure, that's when you get leaking symptoms. So a variety of things impact the ability to manage that pressure, ranging from the hips to the core. And so that's something that we look at as we break things down. We look at how well your core is functioning. We look at some postural positions. We know that if your ribs are kind of flared, that's not going to help your system be in an optimal position to manage pressure. And then we do a lot of hip assessment to see if there's enough motion in your hips and if there's enough strength and control of the hips to allow the pelvic floor to function. Sometimes it might leak because it's too tight and it can't contract and relax to do its job, and some of that can be very influenced by the external anatomy and function of what's going on outside of the pelvic floor, which is something that we dive into in assessment to figure out the root cause of what is going on.
We can also do, like with pelvic floor therapy, so Annalie does the external stuff and I do the internal stuff, so I'm like checking muscle tone and stuff like that by inserting my finger through the vaginal canal. But essentially, a lot of times I see internally when people are having issues with leaking, like stress incontinence specifically, it can be a muscle imbalance. So it could be like one side of the pelvic floor is tense and the other side just isn't. And so when they're doing like a pelvic floor contraction, or what people like call it Kegel, it could be like one side is actually contracting where the other side just isn't even contributing at all. And so it's not fully closing to stop the air from coming through as well.
And what's always fascinating, I always like nerd out about this because it's my favorite. So on a first visit, I spend a lot of time asking kind of questions, understanding the history of what your symptoms are and what you've been dealing with, and then I'll do kind of my orthopedic exam to look at those things of your system, of your core and your hips. And then I don't tell Missy my findings, and then I just have her do an internal. I'll let her know just a little bit about the history and the symptoms, but I don't tell her what I find. It's my exam, and then she comes out and she tells me where the tone or the pain and the tension is, and like 99% of the time it correlates with the weakness or the stiffness that I find externally. And so we just combine the two, and then things get really good after that. And we treat the whole system. Treating, like if you were just to try to do pelvic floor contractions and pelvic floor muscle training, oftentimes you don't get to where you want to be because that's more of a compensation or a secondary issue. There's an underlying issue that's going on that needs to be addressed in order for that pelvic floor to function how it's supposed to.
I would also say, like, women hear all the time, do your Kegels, do your Kegels, do your Kegels, right? Do you guys know what that means? What does that mean? What are you doing when you're doing a Kegel?
It's tighten.
Just tightening?
Yeah.
Do you know for a fact you are actually tightening? Because I would say probably more than half of the people, while I'm doing an internal assessment, I'll say, okay, perform a Kegel for me. And I'll, like, if I won't give them any clues or anything, I'll just say, perform a Kegel for me. And I would say probably over half of them are doing it incorrectly. And so just giving the dose of doing a Kegel at a stoplight isn't something that's really going to be beneficial, because most of the time they're not even doing it correctly in the long end. And most of the time, like if you're having a tense pelvic floor and that's the reason why you're having the issues, doing a Kegel isn't going to solve that.
Yeah. I've talked about that at a previous workshop. I don't know if anyone was here, and I did that a couple years ago, but I use the analogy of like a shortened bicep. So if your bicep, if for whatever reason had an injury, you were overly tight in your bicep and didn't have the range of motion to move your bicep to lengthen it and shorten it. If someone told you to just squeeze your bicep, like that's not going to get you anywhere from the function of that elbow. It's exactly what's happening if someone has an overly tightened, shortened, painful pelvic floor. Doing Kegels is just that exact same thing, but for your pelvic floor, and it's just not going to get you where you need to be.
I would say I maybe diagnose a Kegel exercise to someone, like one patient out of every 15, 20. Like it's not, most of the time I tell them to just forget Kegels.
Yeah, most of the time especially because there's pain involved, and usually if there's pain of some sort, then there has to be some relaxation that's happening before we can get into that. And then if you get things to relax and you get the external things to function appropriately, then the pelvic floor all of a sudden does what it's supposed to do, and you don't have to do that conscious contraction.
Are there any other questions specifically you guys have on leaking with pelvic floor or anything like that?
Did you say why you leak? Is it it's a muscle tone thing, and is it because it's overly tight, or is it?
It could be
either
it's
way.
different for everyone. There's some people where they just have their pressure is not able to regulate itself, and so that's something that we are having to kind of help them figure out, is how to control their core to be able to get the pelvic floor to also function. Or it could just be that they really just don't have the muscle tone in the pelvic floor, or the muscle tone is too tight and so it's not working properly. It's different for everyone, honestly.
Yeah, the mechanics there's a pressure issue, management issue. It's not like leaking specifically. There's some leaking with stress, so whether it's coughing, sneezing, jumping, lifting, running, that's kind of an activity related leaking. It's a pressure management issue where there's too much pressure inside that's pushing downward on your pelvic floor that is not managed well. And it's not managed well because pelvic floor could have any of those issues, or there's an external thing going on from the low back, from the hips, from the core, that's not allowing the pelvic floor to function how it should be. So there's some root cause of why there's a pressure management issue.
Another question.
Yes.
How many times do you see someone who hasn't had babies have issues with leakage?
A lot too. A lot of it just comes from not necessarily having that coordination. And so that's like what we're doing is helping do, like, full transparency here. Last year, I got really sick and I had the flu and I was throwing up and I was peeing my pants. And I was like, I've never had a baby. And I was like, I am a pelvic floor therapist. Why am I peeing my pants? You don't have to have a baby in order to
Thank you.
have issues. There's also too, like, so we talked about stress incontinence, but there's also urge incontinence. So that could be things like, oh, I have to go to the bathroom right now. Like, if I don't make it to the toilet within 2 seconds, I'm gonna pee my pants, and that's not normal. Just putting it out there. Peeing when you are exercising, even just a small sleep, is not normal. That's something that we can help.
Yeah, very common, not normal, not something you have to live with by any means.
Are there times where you feel like a surgery is necessary, or do you guys find that you're able to like resolve it just through exercises?
I don't think we've had any cases come in where they needed surgery, and we've worked together for 2 years at least now. So I don't know if those extreme cases just aren't getting in the clinic. I know that some people do get surgeries, but the cases that have come into our clinic haven't needed surgery. Usually surgeries are going to be recommended for people who have been diagnosed with more of a severe grade prolapse. But even if that's the case, even doing pelvic floor type therapy before that would just help you with your outcome after. I know people who've had surgery and still struggle with other symptoms because they haven't addressed some of those other causes. But it can be a helpful option in certain cases.
How much time does it usually take for therapy from beginning to end?
Beginning to end.
I know that every case is different and
Yeah.
that's hard, but some people are impatient and think 6 weeks is enough.
So I would say in general 6 to 8 weeks people are doing really good by the 6 to 8 week mark. We have a patient right now who, hers is a cool case. It's not related to leaking, but she has pain with intercourse. She's been married for over a year and hasn't been able to successfully have sex with her husband. And when she told me this, she was emotional. You could tell it's really impacting her life. And in just like 4 or 5 weeks, she's 80% better. Has been able to have sex for the first time with just a really short amount of treatment that she's been really consistent with. So it can be really impactful. And pelvic floor is really cool because it usually responds really well once you find the right things that you need to work on.
I feel like it's pelvic floor usually is a case where we start out seeing you pretty frequently, but then you're able to just go to like 1 time a week just for like management pretty quickly.
Sorry,
Yes.
I have all the questions.
Ask away.
So are you planning to show us some examples of some therapies that you do for pelvic floor?
Yeah, we're gonna look
That we
at
can
kind
do
of some
appropriately.
assessment stuff. And then, yes, we're gonna look at some foundational things that we established first for most people.
Do any of you guys have like pelvic pain? I know that's kind of like personal, but you do?
Like, I don't know if that is exactly what it is, but I have pain like a couple times a year. Then I have,
Okay.
like, it's not all the time. It's like
Okay.
if I do too much or something like that, then, yeah, and then it's in my back usually.
Okay. So I'll tell you kind of like with pelvic floor pain specifically, that's where like internal stretching can be really helpful. So that's where I'll go with my finger through the vaginal canal and I'll palpate through each layer individually. So like I said that there's 3 layers, right? And that first layer is literally just like the tip of my knuckle. The second layer is the second one, and then the third is like my finger all the way through. So while I'm doing like an internal assessment, I'll kind of palpate to see if I notice any tension more in one area versus the other, kind of like what I said. And I can also check like the power of that muscle, the endurance, like how good the repetitions are. But with like pelvic pain specifically, I have like a printout where if I do find something where I'm able to recreate that same pain, so like your back pain, if I were to do an internal assessment, there's a good chance that I could be able to just recreate your back pain just by doing that. I had just a patient the other day that I did an internal assessment on. She's been going to like chiropractors for over a year. She's been like trying to figure out what's going on. She had hamstring pain, she had lateral hip pain, and she had some groin pain, only when she's running. And during my internal assessment, I was able to target each one of those areas by palpating a different part of her pelvic floor. So we know that like, yes, she's been going down this avenue for so long, and just by doing that one assessment, I was able to recreate her pain, which is pretty cool.
Yes.
Do you typically find that like scarring can cause some of that imbalance?
Yes. Yes. And people always ask if I can feel the scarring, and yes, I can.
Yeah.
Yes. Any other questions on pain specifically? And then we'll kind of get to some other stuff. With prolapse, just to like kind of educational base, if you have like a heaviness, or if you're noticing, a lot of times people will say like, well, I just went to the bathroom, I stood up from the toilet, and I feel like I have to pee again, so I have to sit back down. And I like pee, and there's a little bit more left in there. A lot of times that can happen if you have a prolapse. So when I'm doing an internal assessment, I'm able to check to see if you do have a prolapse, and I'm able to grade it. So they go from grades 1 to 4. Usually with pelvic floor PT, you're able to get it better by at least a grade or 2, just with pelvic floor PT. So in those cases when you are like a 4, like surgery may be an option there, but not necessarily something that we would have to do. But there's 2 types of prolapse specifically. There's a cystocele and a rectocele. So cystocele is when the bladder is essentially pushing down through the vaginal canal. And a lot of times that's like when you feel like you have to pee, you go pee, you get back up, you're like, oh, I still have to pee, you sit back down. A lot of times that could be the cause of it. And then a rectocele could be where you're getting like a lot of constipation or something like that, because that's when the rectum is pushing through the vaginal canal. So essentially when you're bearing down, using the restroom, putting pressure onto that pelvic floor, that's like causing the rectum or the bladder to not be like in proper alignment. Does that make sense?
Mm-hmm.
Okay.
Yeah, difficulty fully emptying your bladder, difficulty initiating the flow of urine, constipation, not being able to delay voiding. Those are all bladder signs of potential pelvic floor dysfunction. That
A lot of
really,
like frequent UTIs too.
yeah.
We see that a lot.
Yeah. Yes. I heard some confirmations in here.
Yeah.
Yeah, so what happens with UTIs, if you have even just a grade 1 prolapse, and there's some dysfunction there, you're not getting that full emptying, and so that urine stays in the urinary tract and then develops into infection. So as you improve the function, you can fully void, and you have much less frequent UTIs, and life is good.
Free tip: everyone should have a squatty potty.
Do y'all know what a squatty potty is? You guys heard of it? The word's
They're
getting out.
beautiful. They're beautiful with their pelvic floor.
Okay, we wanted to kind of do a little bit of a more interactive section here where we look at some hip function, kind of an external exam for yourselves to see how well your hips are doing. So Missy is going to be my patient, and
Why don't we have another?
because they're going to do it on each other. Oh, okay.
It's like I can be
That works too, either way. So the hips directly impact the pelvis, which directly impacts the pelvic floor. It's kind of hard to imagine this, but I use the analogy of a hammock. So the pelvis, the bony parts of the pelvis are like the sturdy ends of a hammock. The sling in the pelvic floor is the part you lay on in a hammock. If you bring the ends of the hammock closer together, we know that the sling decreases, it gets lax and loose. if you take the ends of the hammock farther apart, it gets tighter. Does that make sense? So, same thing happens with the pelvis. If our pelvis kind of rotates closer together, the bottoms come closer together, the pelvic floor gets more lax, which is helpful for birth, which is helpful for someone who has an overly tight pelvic floor. We want to be able to access a lot of that position, which we'll go over what position that is. But if you're having a lot of leaking, we want that to be more tightened and supportive, which we would want the pelvis ends to kind of come apart. And the hip positions that correlate to that is hip external rotation means that the pelvis is kind of coming together. There's a little bit more slack in the pelvic floor, which is why we tend to birth with open legs versus closed legs, obviously. That wouldn't go so well. And then when we put our hips into internal rotation, it tightens and it takes the slack out of the sling and brings the ends of the pelvis apart and provides more support, which is why people will often go like this if they're coughing or sneezing. Hips are going internal rotated position, and it helps put your pelvic floor in a more supportive position. So first we want to see the mobility. Do we have good external rotation? Do we have good internal rotation? Both are important for a good pelvic floor function. So that's the first thing that we're going to look at. And you guys are going to help each other out here. And I'll help you know what to look for. So one of you will will be laying on your back, and then the other one. That works. Come, Megan. So one of you will be laying on your back.
So we need to partner up right now? Or?
Partner up.
Yeah, partner up.
She's so good.
Yes, Missy can tag in if you need to. So you're going to grab your partner's leg and take the knee up to where it's over the hip here at 90 degrees. Alright?
Who's going first?
Who does not have a partner?
Was everybody ready? Okay, so now you're going to keep the knee in place over the hip, and you're going to move the foot inward towards their other leg. And so we are looking to see if we can move at least 45 degrees there. More is a little bit helpful.
Tight hips here.
Missy can come help you eyeball if you're not sure. So we're looking at your hip external rotation here. So this is hip external rotation, not to be confused because your foot's going inward, but your hip is actually moving outward. I promise. Okay, everybody got do this on both sides actually. Kind of compare side to side. See how your right side is, Megan. It's not uncommon for one to be a little less or a little more than the other. So kind of comparing side to side. Okay.
Are we going out?
That was just external rotation on both sides. Now we're going to go the other way. So make sure the knee stays nice and centered over that hip, 90 degrees. And now we're going to go out where this one might be a little less. Ideally, you're still getting close to that 40 degrees. Some people are accepting 20 degrees. I get like 10. Okay, if you have a limited internal rotation at the hip, then that is something that can really impact your pelvic floor's ability to get into a position of support. And so some people are a little bit more prone to leaking if they have that stiffness in that direction.
So they're more prone to leaking if they have
Less.
poor internal rotation.
Do we switch now?
Yeah, go ahead and switch.
Chamber.
And you said ideally internal rotation should be 20%.
It should be like minimum 20 degrees, but still like ideal for 40 to 45 degrees. That would be internal rotation. That way it's external rotation.
Because it's the way your hip. Yeah, it's the way your hip.
So if you look at the hip,
Is there one that's higher than the
my mom gave me some pretty suggestions. No, but like how far is there like
whatever your body can do. I don't know what to say for external.
Yeah, because if it's coming inward in that position, then it's external rotation.
Okay, so you're external.
You look at the femur and what way is it moving.
Did anyone have like a big imbalance from side to side?
Well, that was really.
Was it more with the external rotation or internal?
One leg was better than the other, and then switched it.
You were not the one?
Okay, one leg was better internal,
The other one
and the other one was opposite, better, yeah.
Oh, because
We see that a lot.
you went out better than.
Yeah. Does that show you something, like when it's like that?
That's foretelling of potentially just kind of like lifestyle positions that we assume more so. Like I remember when I was in school, I would always sit with this leg up, and so my external rotation got really good on this leg, but then this one was like left behind. But, okay, so it's one thing to have the mobility. That's step one. If you don't have mobility, muscles can't function how they want or how they should. But then it's another thing of being able to control that range of motion. So you just had someone passively moving your hip there. That's more of a flexibility kind of assessment. So now we're gonna look at your strength to see how the strength of the hip external rotators and internal rotators are for you. So we're gonna do this in sideline. This isn't like the textbook definition of how you test, but you can still get a good idea of where your strength is with this. It's just a little hard to do it on the ground the other way. So we'll do it this way for tonight's sake. So Megan's gonna lie on the right side. And you're going to, most of you have probably done clamshells before,
No,
assuming. Never, ever. Okay. So we want to get the hips flexed to about like close to 90. Not really 90. It looks like 90, but it's not like dead 90. But 90 degrees at the knee here. It's more like 50, 45-ish. As long as it's not too straight, you should be okay. The feet stay together and the hips stay stacked. You're going to want to roll the hips back when you're testing here. So your partner can kind of block on the pelvis there to keep your hips forward. And then Megan's just going to rotate her knee up towards the ceiling. Good. And then kind of go up as high as you can there. And then you're going to push down on it and gradually add pressure. If someone has hip pain, probably would not recommend having a stranger push on your hip there, but if you don't have hip pain, then you should be okay to do this. So go ahead and lift again, Megan. So you're gonna just gradually add pressure, and you're just gonna see if they can withhold the pressure, or do you get to a breaking point? So that was pretty good. So a little bit of give, but didn't like fully break. I'm gonna, so this is testing external rotators of your hips. Now we're gonna look at internal rotators. So now Megan's gonna keep the knees together and lift the foot up. And then she's gonna hold the foot up while I try to push down that way. And we're gonna, and so we're just gonna kind of screen this. It's not gonna be like, we're not trying to get crazy specific. You just wanna know if it's like fair or good or great type of thing. So kind of like a scale of 3, like does it go down pretty easy? Is there some fight and then you lose it? Or is it like, it's holding, I'm pushing pretty hard, I can't break you kind of thing. Just to get an idea of where that strength is. Does that make sense?
Yes.
Okay, we'll walk around and kind of help you out.
and it was like a cartoon, like
my legs
so
are
like the whole, like, a way I don't need that.
Alright, everybody get a chance. Looks like we got one group still going. Anybody have any questions on kind of that?
She's really strong.
That's great.
I was so weak.
Alright, who knows what the differences between concentric and eccentric contractions are?
They're opposite and one's like concave.
Not quite concave, but they are opposite.
You put yourself out. She tried.
So concentric means that we are shortening the muscle when we're contracting it. So if we look at a bicep curl, pulling the weight up, the bicep is coming shorter here, and then when we lower that weight down, the muscle is lengthening while it's still controlling and while it's still working. If you were to push the weight down, that's more of a concentric exercise of the tricep, not the bicep. Does that make sense? So shortening is concentric, eccentric is lengthening, but the muscle is still doing the work. So what I sometimes see in the clinic is some people might have good range of motion and they might have good static strength, but they don't have good eccentric control, which is super important for pelvic floor function. So it's specifically external rotator eccentric control. And what that looks like in our position on our feet is when, if we were doing like a hip airplane, I should do that on not wobbly. If we go into a hip airplane, our external rotators are rotating the pelvis upward and getting shorter on this side. So my hip is moving into external rotation here. For eccentric control, it does the lowering, but when we're training it in the clinic, we add all of the range of motion, and so we go into internal rotation of that pelvis on the femur there. And doing this specific muscle control training helps the hips perform better, and then also gets your pelvic floor moving through those positions in a smooth, controlled way, and just cleans up a lot of issues that we see from prolapse issues, pain from compensation, or leaking. So that's kind of the foundational thought process, and then we progress in movements based off of if it's movement specific that you're having symptoms with, then we get to the specifics of those movements, or we just progress in difficulty as your body changes and adapts. Does that all make sense there? That's probably like the biggest unique thing that you probably won't really come across on the internet when you're learning about pelvic floor things, is that specific thought process. That's kind of a foundational thing that we build on when we're treating it. Cool.
Any other questions?
Anything that we didn't talk about that you're hoping we talked about? Would talk about? Yes.
Some exercises for us to do?
So I can give you a bunch of general exercises, but I don't know how helpful that's going to be. A lot of the stuff that you do regularly in the gym are targeting those muscle groups, but it depends on if you have stiffness or limited range of motion. There's mobility things that you want to work on first. If you have strength issues, then you want to work on those if you have the appropriate mobility. And then if the strength is decent but you're still having symptoms, then it's likely working on that thought process that I just talked about of that eccentric control of getting your pelvis to move on your femur. So hip airplanes are really great. RDLs are really good, but we'll sometimes add that rotational component to those. Split squats can be really helpful, but it all depends on where you're at. Some people, the pelvic floor's got a lot of tone in it. That internal stretching and assessment is going to be really valuable to know if your pelvic floor can't fully relax. then we need to work on that first before those other exercises will be as helpful. Does that make sense? But those are all good places to start, just isolated kind of hip exercises, those kind of things. And then if you're still having issues, then the quickest way to see change is to get dialed in of your assessment and what you need. Yes.
You were talking about, something about 1 week as you're trying to, like, at the end, so how often do you do physical therapy in the beginning when you're actually doing the?
I would say most of them will start at twice a week. If someone's coming in with a lot of pain and it's been going on for a long time, they get results quicker if they do like 3 times a week for 1 or 2 weeks to get that volume of internal stretching going. But if it's more of like a leaking prolapse issue, then we usually start with twice a week to kind of make sure that movements are being performed well and that they're at the right level of difficulty for you, because you usually progress through things pretty quickly in the beginning, and then you kind of hit this like slower phase, and that's when we know that we just need a little bit more time for these adaptations to occur, and then we decrease to once a week at that point. I would say in general it's 2 times a week for 4 to 5 weeks, and then once a week for 2 to 3 weeks.
Okay.
But that all changes based on the person. Yes.
Do you have to have a referral from a doctor to?
It depends on your insurance. If you have commercial insurance, like non-Medicare, Medicaid, TRICARE, and workers' comp, then you do not need a referral. Those are the government insurances are the ones that still require referral, but legally, in Utah, you do not need a referral to go to a physical therapist, but those insurances will require it. But if you've got Blue Cross Blue Shield, Cigna, Aetna, U of U, Select Health, you're all good to go. You don't need a referral for those. Any other questions? I totally forgot to tell us at the beginning, we have a raffle that Megan has put on for us. So you get a ticket for being here, and then we're going to raffle off 2 packages of 2 dry needling sessions. For
Dry needling? I don't know, have you guys heard of dry needling? Who loves dry needling?
I've heard of it, but I don't know what it is.
Okay. Dry needling, well, Anna can like explain it a little bit better because she's the one that can actually do it. It's super great. It's super great. But if you have like pelvic floor type symptoms, a lot of times dry needling can be really helpful in like decreasing the tone through the pelvic floor. I know that sounds
We don't dry needle the
terrifying.
pelvic
No,
floor.
like
I know, I was like,
you can dry needle the actual pelvic floor, but a lot of times we'll do like hip or adductors.
I was wondering how you would.
Some people are trained in it, and they're not doing, they like go externally like that, where they do that specific muscle that Missy pointed out earlier. But
And also, I guess what I should say too is if like you do not want to have an internal examination, it's super helpful to have an internal examination, but if you do not want to, there are ways to like access pelvic floor muscles externally as well. You just have to get nice, close and personal.
Either way.
Either way, either way, I'm getting nice and close and personal. So we're gonna say there's no TMI, there really is no TMI.
So, sorry, I didn't pick up what dry needling is.
Oh, sorry.
Oh yeah, okay.
So dry needling, we use like acupuncture needles, so they're just a small monofilament, very thin needles, sorry. Very thin needles that we insert into muscles, and we usually use electrical stimulation with the needle. We use it to change, like decrease pain, improve muscle function, and decrease like tone and tension of muscles. So like someone's got a really tight like quad, for example, we could dry needle the quad, and then you have this window of open mobility and decreased tone and tension in the quad, where then you can kind of gain motion faster through that range of motion. So sometimes we do it for the hip external rotators. Sometimes it's more like glute muscles that we need to work. Adductors is really common in pregnancy. that gets a lot of relief for patients. Like for the sleeping pain, I don't fully understand why that is, but I've seen that to be really helpful. And then it can help when our adductors are doing their job well. It really helps offload the pelvic floor and creates more balance around that system. So a lot of tension is carried in the adductors, so it's a really great place to dry needle as well.
One thing I will add, you don't have to do pelvic floor dry needling if you don't want to. I've had dry needling done for migraines, and it's like, you can pick whatever you want, just so you guys know.
Jaw, if you have like TMJ,
I have had my jaw.
or like clench, I love getting my jaw dry needles.
Yeah, so anyways, so just so you guys know, if you do win that, you can do whatever you want.
And Megan is available, like if you were wanting to like have more of a personal conversation for like an injury or or just a screening to see if pelvic floor is right for you. If you're like, no, I want to get this resolved, I want to like get going and treating, then she could schedule like an actual evaluation as well. But yeah, so you guys can fill out raffle tickets.
Yeah.
And we can do the raffle.
Yeah, anyways, so I have a pen over here, and if you just want to come drop off your raffle ticket, and we'll call out the names once everybody gets theirs done. And then, yeah, like she said, so I didn't really explain this very well. I'm a PR manager, so I don't know much about the therapy side of things, but I can demo it and have them demo on me. Anyways, but yeah, if you guys want to get scheduled, I have our schedule here right now. I think it's a good opportunity. Their schedules do fill up pretty quick, and so we'd love to get you on. And we'll have you come in. You'll see Annalie, and she'll do her screen or eval, and then you may potentially end up seeing Missy, kind of whatever they decide is best. But yeah, I would love to get you on the schedule. So, anyways, we can come put our raffle ticket on.
And once you put your raffle ticket in, if you guys have any other questions specifically, you can come ask. Like if they're more